Wow, that's a tough act to follow right there. But thank you very much, Mark, and thank you for having me here. I really appreciate the opportunity to speak to you all. I'm going to be talking about obesity medicine. I'm going to spend most of the time talking about a system that we have developed to massively scale obesity treatment. Because I only have 10 minutes. Normally I would spend 10 minutes on that, and then I spend 50 minutes on everything else, but since I only have 10 minutes, I decided I would spend the 10 minutes on that because I was told this was of interest. But before I do, I wanted to tell you one thing, and that is that, as you may have heard, obesity is now declared a disease. And one of the arguments we always get into is, how could you call obesity a disease? People are just eating too much. They should just stop eating and they'll lose weight. And I know I'm speaking to a sympathetic audience here, but I wanted to give you just one example of the type of work that's going on now that is convincing the powers that be, people at the AMA, people in the government, people at the FDA, that obesity is in fact a disease. And I've chosen this paper by Josh Thaler, but really Michael Schwartz from the University of Washington. The title is Obesity is Associated with Hypothalamic Injury in Rodents and Humans. And what this paper says is that the rapid influx of calories damages critical neurons in the hypothalamus. These are the neurons that conduct signals from the fat cells, stomach, and intestine to the cerebral cortex, where all the processing occurs. And what this paper suggests is that when too much food comes in too quickly, it overloads the mitochondria of these nerves, and the nerves deteriorate more rapidly. They start dying more rapidly. And other work has shown that the stem cell mechanism that supports the integrity of hypothalamic POMC neurons can't keep up. And in fact, if you look at what happens in this paper, as time goes on and mice are fed fattening food, they have fewer and fewer hypothalamic POMC neurons. So what looks like it's happening is that they expand their fat mass to try to amplify signaling through the hypothalamus. So if we think about it, is damage to your hypothalamus a disease? And the answer, I'm sure you would agree, is yes. What's the evidence that that happens in humans? And we have just indirect evidence, and we can't establish cause and effect, but I think that this is an extremely promising and interesting line of research that will revolutionize our field. And let me mention one last thing, which is, so if nerve damage is the cause of obesity, and the thing is, I would propose that this is the ratcheting phenomenon, where weight goes up and it won't go down, right? This is not the addiction, this is not anything else. This is not eating too much food in the environment. I think that what we're going to see is that this is what causes people to be unable to lose weight. So why don't they just lose weight, as Ryan did? It's because their neurons get overloaded. The overloaded neurons can't transmit the signals. Stem cells, which replace the neurons, can't keep up. And it's been shown if you take normal weight animals who can resist fattening food, they have a very robust stem cell mechanism that continually replaces the nerves as they die. No matter how many die, they're replaced very efficiently. And the problem, another problem seems to be, besides fewer nerves, it's the presence of inflammatory cells, glial cells in the hypothalamus. And what's been shown in humans is an increase in hypothalamic inflammation with increasing BMI. So one of the parts of this paper shows that the higher the BMI, the greater the T2 weighted images suggesting inflammation in that area. And I think that, again, I don't present this as the end-all and be-all, but I think that this is telling us that the environment is turning into something physical, and that our approaches have to be a lot more sophisticated than they have been in the future. And that really is one of the key messages. The second is that the recognition that obesity causes more than 60 illnesses that too many of these hormones that come from adipocytes can together cause many of the diseases we spend our time treating in medicine and many other areas. I think that this recognition is another thing that is convincing Medicare, the FDA, very important people, that obesity is worth treating. So as a result, treatment isn't as simple as it looks, and I think that professionally led behavioral treatment is going to be the way things go, that we are in the midst of the medicalization of obesity management. And this is now supported by the U.S. Preventative Services Task Force. They agree that based on their traditional review, we get a grade B recommendation, but that's enough to trigger coverage. And it's been shown again and again to be cost effective. So despite the fact that you may say, well, it's not really that effective, you only get 5 to 10% weight loss, the fact is that it's cost effective, that it reduces the risk of other complications. And that's because when you look at the hormones that we're talking about, they go down much more rapidly than you would expect. And that's kind of a good news, bad news situation, as Ryan's going to find out in the near future, because his leptin levels are much lower than they should be for somebody with his BMI. And what's going to happen is that low leptin state will begin to trigger a lack of satiety, maybe cravings, all of the things that we hear about. And if it doesn't do that, it's going to suppress his skeletal muscle metabolism. As my colleagues at Rockefeller have shown and at Columbia have shown, his skeletal muscle metabolism will be reduced dramatically, 40%, with just a 10% body weight loss. So that's why it's so difficult for people to lose and maintain that weight loss. Not because they don't want to, not because they don't have the willpower. And in order to do this, we need to develop more sophisticated programs to look for problems that can be managed. For example, one thing I'm big on is drug-induced weight gain. We see many patients who come to us who are taking medicines that cause weight gain, and everyone's yelling at them to lose weight. Nobody's changed their medications. And I think that now we're going to see a shift in healthcare as a result of accountable care. We've heard this already at the meeting. That will favor prevention, and that could, in fact, hasten the change to obesity management as part of the care model. So one of the problems with that is that healthcare providers don't know how to treat obesity, and they have no resources. They oversimplify the treatment. They tell people, go to Weight Watchers. They just don't have a clue. And the result has been a failure of the patient and demoralization of both the patient and healthcare providers. So they don't do anything. They don't do anything. They completely ignore it and wait until people develop diabetes, until they develop hypertension, hyperlipidemia, because they're comfortable with treating those. They have pharmacologic management. And I pointed this out, that there are more than 100 antihypertensive agents in 10 different categories, 10 different therapeutic categories. So doctors feel very comfortable treating hypertension. If a patient has a side effect with one, they say, oh, don't worry, we have 99 others. There are actually more than almost 200 when you look at combinations. But when it comes to obesity, if one drug doesn't treat everybody, people freak out. Oh my God, look at that. You know, it's totally unrealistic to expect any drug to treat everybody. If we had 100 drugs in 10 therapeutic categories, we would have effective obesity treatment. And that is a point that we have to emphasize. That is where this field is going for people with established obesity. But prevention, I don't want you to think that I don't believe that prevention is important, but we've got to be doing this in children, because I bet when the day is done, we're going to see that very young children is where this process begins. And that if we don't start early enough, as our good friend Dr. Lustig has pointed out, that it's the process, the die is cast, the injury is beginning. So I believe that there is a need and a demand for a system to deliver care and support to patients, which involves healthcare providers. So our solution, which we've been working on since 2007 and is an outgrowth of my work on the NIH guidelines of 2000. I edited the Guide to Obesity Treatment, which was supposed to go to healthcare practitioners. And when we finished this thing, after years of negotiating with the NIH and everybody else, you know, we had this book, and nobody, I said when it came out, nobody's going to use this. Like, am I insane? And nobody did. And that what we had to do is we had to turn it into something that was useful and immediately available. And that is what BMIQ is. So it is a structured, evidence-based program for live delivery, and it is cloud-based. The program materials for the provider are right there, available to them, in front of them, and there's a complete supporting interface for the patient. So the exact same materials that the doctor uses in the office to manage them is available at home. We have all the bells and whistles that people like, the trackers, things like that, which are the ones that are currently used. Like, we use Lose It. We're trying to get MyFitnessPal's attention, but they're off doing other stuff. So this can be delivered by doctors, PAs, NPs, and RDs are the ones who are using this most now. It's structured if you're a novice, if you have no clue what to do, but we've made it flexible enough so that registered dietitians who are experts can manipulate the sessions. And one thing that we have recently done is made it so that any program can be delivered. So for example, we're in the process of mounting the Mass General's bariatric surgery follow-up program. They want to deliver their bariatric surgery follow-up program through our system. We are putting that there for them, and they will be able to deliver this the way that we deliver our weight loss program. Another hospital system has asked us to mount their program. No problem, we are mounting their program. So we've taken an agnostic approach, like we've seeded it with our material, but we can deliver any program. Pediatric program, no problem. You just have to deliver, you have to put together the materials for the system to deliver. And what we now have is education for the patient, and we also have in the professionals portal education for the provider. So we have continuing medical education credited programs that the providers can go through. We just finished a handbook of obesity treatment with a few colleagues. We're going to have that available, and we'll be giving CME credit for that as well. So we feel we have the entire package for healthcare providers at any level to really finally be able to do what needs to be done. And one last thing is that we have detailed sessions that the patients do. So people always ask me, like, what do you do in the office? Believe me, this covers all the bases. And even if the doctor says, I don't want to deal with this, I want the patient to do it on their own, the system will do it on their own. It can be set so that it delivers the sessions week after week. The patient can come in, be prescribed medicine, whatever, but the behavioral sessions, no one has to deliver them, they can deliver themselves. We've included an expert assessment. This took us a year to build. It's an expert assessment that is built on exactly what we do when we evaluate the patient. So looking for drug-induced weight gain, the system actually looks for that and makes recommendations in a consult letter to the healthcare practitioner. It doesn't tell the patient that. It doesn't say, you know what, your antipsychotic is causing you to gain weight, stop it immediately. No, it doesn't do that. We'd see that on a popular doctor television show. I won't tell you who it is. But what we do is what I believe is the responsible thing and make a recommendation, and we reference it. We reference it so that they can look up the paper if they want to do that and make a suggestion. We find sleep apnea. I can't tell you how many patients we see who are diagnosed with depression, but what they actually have is sleep apnea. Then they got treated with an antidepressant, and then they gained 60 more pounds. And this happens every day. We see this at least once a week in the new patients we see. So the treatment is available, it's flexible, it's professional, and I think that our structured program is effective at a reasonable price point. Finally, okay, you're going to say, what kind of results did you get? This is a program, and right now we're delivering this for our breast cancer patients. The people who are most interested are the people at Sloan Kettering and people at Cornell who are in the cancer space. So they said, okay, we want a program for our breast cancer patients, no problem. 2 weeks, we had this program up and running for them. But this is the result of a program which was delivered at Virginia, in Charlottesville, Virginia, by one of our very good registered dietitians. She put 150 patients through the program. Their mean BMI was 36. And it was 26 weeks. She used a 26-week program. She combined live and online sessions, which you can easily do. They can be in group, they can be individual. They had gym access and 2 sessions with a trainer. The mean weight loss was 6.5%. And I have labs from the first 65 patients. The rest of it is being put together now. Triglycerides went down, the HDL went up, the HbA1c was down 0.3%, even though they were not diabetic at baseline. These are the results of an actual program, the 150 patients, that's everybody. So in conclusion, that's what we have been working on to try to get our program out there for everybody to deliver. I don't have time to tell you any more. So thank you very much for your attention.